Welcome to Pulmonology Read Aloud. My name is Dr. Anshu Maneja Arora, and today we will be talking about a recent update in the world of tuberculosis. This is a special document that has been an update on the treatment of drug-susceptible and drug-resistant tuberculosis, and it is an official statement by American Thoracic Society, CDC, European Respiratory Society, and IDSA. So it's a clinical practice guideline on tuberculosis. And although in India we are not having these updates incorporated into the national TB elimination program today, but here in my country and all through the world, I think the guidelines in future are going to be shaped based on this document. So a very important document with a lot of insight into how TB could be managed, and it is based on recent clinical trial data for the treatment of drug susceptible and drug resistant tuberculosis, and it was uh, it was made by a panel, a strong panel, which comprised of multidisciplinary specialists, around 25 international specialists through the span of pulmonary medicine, infectious diseases, pediatrics, epidemiology, public health, and even patient advocacy groups. And this has been formulated after reviewing evidence and making recommendations using grade assessment and also by a method of development, which means adoption, adaptation, and as needed, de novo development of recommendations based on the PICO method, which is widely common nowadays, where questions are addressed to the joint panel and based on the responses, recommendations are made. So let me first summarize this whole document to you in this one single slide. According to this document, the newer regimen for drug susceptible TB recommendation comprises of a 4-month regimen for people of pulmonary tuberculosis. So primary TB management from 6 months, which was recommended by WHO, by CDC, and by all the national guidelines, that 6 month would change to 4 month once this is adopted. This shortened 4-month regimen is also applicable for children with non-severe tuberculosis. And what that is, I will be talking about it later. As for drug-sensitive TB, there have been changes in drug-resistant TB also. And this document incorporates the use of novel regimen containing bedaquiline, pretomanid, and linezolid with or without moxifloxacin, making the regimen much simpler. So a lot of good developments which will be showcased in this document. First of all, very, very important is the treatment of sensitive, susceptible tuberculosis in adults and adolescents. So, for confirmed INET susceptible, rifampicin susceptible TB in adult, the regimen changes from 6 months to 4 months, and the new regimen involves 2 months of isoniazid, rifampicin, pyrazinamide, moxifloxacin, followed by 2 months of isoniazid, rifampicin, and moxifloxacin. So what is the major change you see here? There is no ethambutol. So ethambutol has been taken off from this 4-month regimen, and the societies conditionally recommend that a 4-month regimen of HPZM followed by of HPZM and 2-month HPM has to be instituted. It is a conditional recommendation, and they mention that there's a moderate certainty of evidence to ask for it. When we talk about the treatment of non-severe presumed INH rifampicin susceptible in TB in children, then in such presumed cases, in children and adolescents between 3 months to 16 years of age for non-severe TB, where we don't suspect MDR, we can give the regimen of 2-HRZ with ethambutol and 2-HR. So here 2-HRZE, and why they've placed ethambutol in the brackets is because sometimes it may not be possible because of any drug related adverse effect to give ethambutol, and in that case this drug may be additionally added or taken off. The regimen stands at 2-HRZE and 2-HR. So 4 months for children instead of 6 when it's a non-severe TB. And when we talk about non-severe TB, they clearly demarcate that this includes peripheral lymph node TB, TB involving the intrathoracic lymph nodes but no airway compromise, TB pleural effusion, possibacillary non-cavitary disease, extrapulmonary disease, or disease confined to one lobe of the lungs only with no miliary pattern. So possibacillary disease, TB pleural effusion, intrathoracic nodes but no obstruction, or peripheral lymph nodes, and that's when you could give 4 months of treatment instead of 6 months of treatment. And those children and adolescents where this criteria for non-severe TB is not met, they should, and I repeat, they should continue to receive the standard 6-month treatment regimen, which includes 2-HRZE and 4-HR, or the recommended treatment regimen for those severe forms of extrapulmonary TB like TB meningitis or spinal TB or bone and joint disease, where the 4-month regimen will not work. Some children may also be eligible for the 4-month rifampicin moxifloxacin regimen that I mentioned in my last slide, because they may be in this age group of around 16 years, and that has to be taken into consideration on a case-to-case basis. But this is a strong recommendation with moderate certainty of evidence and will definitely help cut down the treatment duration in children with non-severe disease. The third recommendation comes around treatment of rifampicin resistant, fluoroquinolone resistant tuberculosis. And here, when we talk about rifampicin resistant and we're talking about drug resistance, the 6-month regimen, BPAL regimen, which is very popular now, has been included. So they've studied the 6-month bedaquiline, pretomanid, and linezolid regimen, the evidence behind it, versus the 15-month or longer regimens in adolescents above 14 years and older adults. And based on the data, they have recommended the use of a 6-month BPAL-M regimen, which is a very strong recommendation, but with very low certainty of evidence because the data is not as huge. But the recommendation is very strong that instead of giving the 15-month toxic regimen, we should prefer to give the 6-month BPAL-M treatment regimen in this scenario. In adolescents aged 14 and older with rifampicin resistance and with intolerance to fluoroquinolones where you can't give it, or resistance, who in patients who've either had no previous exposure to bedaquiline and linezolid or have such an exposure for less than a month. This 6-month regimen is a strong recommendation by this guideline. So what is the evidence behind these recommendations? So they have looked at the evidence from several studies, of which when we talk about the drug sensitive treatment recommendation evidence, they've mainly sourced it from study 31A5349, which was a randomized open label phase 3 trial that compared two regimens, which were 4-month rifapentin containing regimens with the standard 6-month control regimen. And they have taken participants above 12 years or more in this trial, and all with newly diagnosed pulmonary TB. This trial was done at 34 sites worldwide, and the outcomes that they've looked at is the outcome of TB disease-free survival at 12 months post-randomization as the cure or the favorable outcome. They've also looked at treatment retention, they've looked at acquired drug resistance, and they've looked at adverse events which were grade 3 or higher, and all cause mortality within the 14 days of last dose of the study medication. Now, this analysis, which was done in so many countries, has had 791 participants, and this has been in the drug arm, the 4-month rifapentin moxifloxacin arm, and 768 participants in the 6-month control arm. And they have all been culture confirmed susceptible to INH rifampicin and fluoroquinolones. So what they've seen is that rifapentin and moxifloxacin was non-inferior to the control. So the percentage of cure 84% versus 85.4% in the 6-month regimen tells us that we could use this regimen for cure. They haven't seen any significant differences in outcomes for the rifapentin moxifloxacin versus the 6-month regimen. If you talk about the smear grade, about the cavitation, the radiological extent of disease, the age, diabetes, body weight, HIV status, or other factors. So there hasn't been much change if you look at individual factors. But yes, when we talk about patients with special conditions, comorbidities like HIV or diabetes, or patients on extreme age spectrums, the number of patients have not been too high. So, but there have been patients, almost 9% of the trial patients have been HIV positive, and they've taken patients with CD4 count more than 100 in this trial. And most of them have been young people. This trial had also monitored for side effects by ECG for patients at risk of cardiac events, and they haven't really found much significant difference in the adverse effects also. So, rifapentin and moxifloxacin regimen has also been seen in trials around pregnant females, and they have not found any unfavorable pregnancy outcomes in trials with rifapentin and moxifloxacin and INH together, including weekly therapy for latent TB infection treatment when we talk about INH and rifapentin. So, overall, the recommendations by the World Health Organization on the basis of this multi-center study has shown that this regimen is equally effective. The only thing that one has to remember is that this does not include patients with severe tuberculosis, with CNS involvement, with bones, joints, miliary TB, pericardial TB. And so in them, you would probably go ahead and treat with your normal 6-month regimen and not a 4-month regimen based on this evidence. Coming to the other trial, which is the trial that was looked at to when the recommendations for children were made, the SHINE trial. So the SHINE trial was analyzed for critical outcomes for the treatment of non-severe presumed INET susceptible, rifampicin susceptible TB in children. And this was again a non-inferiority randomized trial which had these two arms, the 4-month therapy arm and the 6-month therapy arm in children less than 16 years of age. And they had to be symptomatic but non-severe TB, which, as I mentioned, includes lymph node TB without obstruction or uncomplicated effusions or possibacillary or non-cavitary disease, but not miliary disease. The SHINE trial enrolled almost 1,200 children and adolescents under 16 years of age, weighing more than 3 kgs. They excluded patients who were known to have drug resistance or were in contact to persons with drug resistant TB or pregnant females or TB, which was more severe, like the miliary TB and TB meningitis. The success rate of this trial showed 96%, 96 to 97% success outcome in participants receiving 4-month regimen, which was 2 months of INH rifampicin pyrazinamide with or without ethambutol, followed by 2 months of INH and rifampicin. And this was in comparison to 96% amongst the people receiving 6 months. So this also shows that this regimen has promise, and in children with non-severe disease, a 4-month regimen with just 3 drugs initially or 4 drugs could be helpful to cut down the duration of treatment. So this is how you can identify children eligible for 4-month regimen. A child between 3 months to 16 years of age with clinically diagnosed confirmed TB regardless of symptoms, and the smear is negative or it's a possibacillary disease, no drug resistance, then you do a chest radiograph. If you see peripheral lymph node TB, 4-month regimen can be given. If there's less than one lobe involvement, non-cavitary disease, pleural effusion, again it can be given. If you have more than one lobe involvement or a complex effusion, then you give the standard 6-month regimen. And if there's a suspicion of extrapulmonary TB in form of meningitis or miliary or skeletal TB, then if your patient has more than one lobe involvement and it's a severe TB, you would prefer to give the normal regimen. Otherwise, children 12 years or older with drug-susceptible pulmonary TB can receive the adult 4-month rifampicin moxifloxacin based regimen. That provision is there. So this is the subgroup analysis and consideration for 4-month regimen in children. If a child has asymptomatic disease, the child was not studied in this study. So asymptomatic children with non-severe TB can receive 4-month regimen because they were not eligible. So the SHINE study does not mention. In children with peripheral lymph node TB, they were included in the TB study, the SHINE study, and the management considerations is that the peripheral and intrathoracic lymph nodes may remain enlarged and regress, so 4-month regimen will be recommended. For children living with HIV, you need to monitor them, especially with severe HIV, and you may need a 6-month regimen. Children with severe malnutrition, again, it hasn't been a subgroup, so you should preferably give a regular regimen. And when we talk about infants, they were not a part of this study. Study included children more than 3 months, so infants less than 3 months were not included, and they need to be treated with a regular regimen. And it does not include patients exposed to drug-resistant TB, so there you have to follow the appropriate regimens. Coming to the data behind drug-resistant TB, the TB Practical Xenix trial, these were the two main studies, along with comparison with the WHO's long SOC regimen registries that was looked at while making the recommendation of BPAL-M regimen. So here we've seen that earlier, the global success rate for MDR-TB was very low, 50 to 80%, and there were a lot of side effects. But some of these studies, like the NICS TB study, demonstrated a very good success rate to the tune of 90% for XDR or MDR TB when the BPAL regimen was used over a 6-month period. So, taking this forward, this committee looked at the TB Practical study and the NICS study and the XENIC study to look at open label RCT of BPAL versus the long regimen. And they also looked at the adverse events, they also looked at the dosaging and treatment durations. So the WHO compared the XENIX trial data with the programmatic individual patient data of the longer regimens. And they analyzed the data from this pragmatic clinical trial study, which was for a concise and less toxic MDR-TB treatment regimen. So here they looked at 181 patients in the XENIX trial that received 26 weeks of BPAL and or they received a different dose of linezolid, BPAL 1200 for 9 or 26 weeks. And they also randomized these patients for this 1200 or 600 milligram daily for 9 or 26 weeks. And they noticed that treatment with 600 milligrams of linezolid in the treatment regimen had favorable outcomes, lesser peripheral neuropathy as compared to 1200 milligram dosing. They also compared this XENIX data and data in the TB Practical study. And in the TB Practical study, the BPAL was used for 24 weeks and linezolid was initiated at 600 milligram. This study also showed that as compared to the longer TB regimen, the success rate in these patients was 77% versus the 52% success in longer regimen with much fewer side effects. So when we talk about MDR or rifampicin resistance or pre-XDR TB, these shorter regimens proved to be more efficacious and lesser toxic. They looked at the success rates of 76% in practical study compared with the BPAL M regimen, compared to 51% in the long SOC with injectables, and 73% compared to the with the XENIX trial. And the adverse events and the death was also much less. So they recommended that the BPAL M regimen could be used for MDR XDR TB, and individuals who have experienced rifampicin intolerance could also be potentially eligible for these regimens. Also, they continue to maintain in the guideline that the longer regimens are recommended for children less than 14 years of age right now and for lactating and pregnant individuals because we do not include them in these trials. When you are using these regimens, especially the bedaquiline treatment, it has been emphasized that baseline and follow-up ECG with QTC measurement are necessary. And when we talk about pediatric adverse effect profile, also bedaquiline has a favorable profile. But since we don't have much data for linezolid and predominant, we cannot at this point of time recommend these regimen for children with drug-resistant tuberculosis. This is the monitoring plan given for patients treated with BPAL or BPAL-M regimen. And this is how it should be followed with all tests, including sputum, imaging, weight, symptom review, drug sensitivity, CBC, kidney profile, liver profile, electrolytes, and HIV pregnancy testing, vision exam, neuropathy assessment, arthralgia, amylase lipase being done at baseline, with serum drug monitoring being done at 1 month of treatment and regular monitoring being done till 9 months of treatment, as well as post treatment for around 24 months. So, coming to the recommended drug regimens again, and to summarize, the recommended 4-month rifampicin moxifloxacin containing regimen will contain H, P, Z, and M. Isoniazid is in the same dose of 300 milligrams daily, rifampicin 1200 milligrams daily, pyrazinamide weight based, and moxifloxacin 400 milligram daily. For non-severe TB in children, which is susceptible, HRZ with or without E can be given in the weight band related doses. In rifampicin resistant fluoroquinolone resistant TB, there is a recommendation of B-PAL regimen, bedaquiline in the dose 400 milligram daily for 2 weeks, then 200 milligram 3 times a week for subsequent 24 weeks, preterminate 200 milligram daily for 26 weeks, and linezolid 600 milligram daily for 26 weeks. As I mentioned, through the Xenix trial, they observed that 600 milligram is more efficacious and less toxic than 1200 milligram of linezolid. In the treatment of rifampicin resistant but fluoroquinolone sensitive TB, moxifloxacin will be added. So the regimen will be the B-PAL-M regimen, where bedaquiline, predominant, linezolid, and moxifloxacin will be given together. So these guidelines have made TB treatment much more simpler. However, you have to remember that this is not what is being followed nationally by the National TB Elimination Program in India, or even in a lot of countries where their national and regional programs are running. It's a good indicator of how TB management can be incorporated, but we'll have to see how it is done with more studies locally in future. The main limitation of this guideline update, though, is methodological, because it uses the method of development of adapting the recommendation, so the level of certainty of evidence is not as good. Secondly, a lot of these references that have been looked into have been taken from WHO data, which probably has not been reviewed as a raw data. So we are taking it into consideration, and that is one pitfall of this guideline statement. They are also acknowledging that for all of these 4 PICO questions, they have again specifically focused on the WHO recommendations based on the prior guidance. So they haven't included a lot of newer regimens in these PICO questions, which could have been included. And they've also mentioned how the 9-month regimens are also available, but they have compared this drug resistant TB regimens with the 15-month regimen. So that is something that was lacking. And the certainty of evidence for some of these outcomes was very low. But since the benefits are good and the side effects are less in the all oral regimen, they do favor the shorter regimens. And they also do acknowledge that in patients with severe TB or drug resistant TB or other severe forms of EPTB, the studies have not been included. So, this document's focus is TB low incidence, high resource context, whereas WHO looks at TB high burden, low resource settings. So there's definitely a gap in knowledge, but the strong recommendations coming from shorter regimens is really, really appreciable because it may change further how TB is being managed. They do mention that their overall recommendation is a DST to guide therapy and DOT as the standard of care for TB treatment. So, with that, I conclude this topic. If you liked this video, if you think that it was helpful, then please share this video with your friends and colleagues. Do subscribe, like, and share Pulmonology Read Aloud. And if there are any specific suggestions or topics that you would like me to read aloud, then please do mention in the comment section. Thank you very much and happy reading.